Good morning and greetings from Mount Sinai Cardiac Cath Lab, New York, to our faculty and Medquest, and of course Vijan Joseph and Jimmy George. I can see both of you, and this is our Sun Pharma Mediquest live cases series, which exactly today is our second anniversary, end of second, means 24th case today, which we started clearly 2 years ago. So if we can show the slides, and these are our usual the faculty and our staff of the cath lab, Dr. Keeney, my left side, and our intervention fellow on the right side with Ali and Vishal. So, and many of the faces you'll see, and if imaging is needed, the Kiski will be there. So this is our complex coronary live case series with the CCC live from Cardiac Cath Lab, Mount Sinai, and CME Mediquest. So no new disclosures for both of us. Then both guest faculty, Vijan Joseph and Jimmy George as the moderator. Clearly, both of you I know very well, have met in many meetings, and I'm so thankful to both of you to be as part of this our educational series at working at Leslie Hospital, Kochi, Kerala. And Vijan Joseph is a consultant cardiologist and has done his training and very expert in performing complex interventions and published numerous papers. Dr. Jimmy George is a senior consultant interventional cardiologist at Leslie Heart Institute, and more importantly has served on many of the organizations in various positions. And we are so thankful to him to clearly put our India name and more importantly, the academic and teaching, which Dr. Jimmy George has done. With that note, we come to our case. Today, we'll have this case of the RCA, CTO, whether antegrade or retrograde. We are ready for both. And then we'll go up to show, you will show us that don't give up the first sign of struggle, keep going, managing a calcified lesion, and then we have interactive panel discussion. So this is case number 24, 63-year-old male. Didn't have much history until a few months ago when presented with class 2 angina and has a stress echo for multivessel ischemia. Normal ejection fraction, controlled hypertension and hyperlipidemia, ex-smoker, SAQ score, that tells you like angina quality, quality of life. Anything 0 is worse, 100 is good, so he has 52. He was on aspirin, metoprolol, torvastatin, losartan, and then he had an angiogram done on August 15th, which revealed 3-vessel disease. There was a long LAD, calcific mid and diagonal bifurcation, the 90% proximal circ, 100% proximal RCA, filling via bridge and retrograde collaterals, normal EF, syntax score of 30. Patient underwent PCI of the circumflex using Synergy DES and started on ticagrelor and isosorbide. Mononitrate, and now is for stage PCI of the RCS CTO using antegrade and it failed retrograde collaterals. Yes. And you want to show the angio? Okay, let's show the angiogram now before we go on further.
We are with this right side, so you can see the complex stent. Of course, we have the LAD lesion mid. Didn't take a cranial picture. EF is okay, and this is where we are with the RCA, where you have proximal total occlusion, and you have good collaterals from the left side. Let me just.
So both, it looks like an antegrade as well as retrograde collaterals.
Yeah.
And good one septal looks like filling
There's
nicely.
Good septal coming.
And our always goal is that we try to do antegrade if possible. Of course, if antegrade fails, you always have to be ready with the retrograde. Good. So this is where we are now.
Okay.
They're taking a
when
picture.
You're doing a retrograde and you have to see the septal collaterals, I'm going to inject first. So it's a good septal to septal, and now you have the right also good.
So actually very good collateral.
Exactly. Yeah. Like, shall I just
yeah, of course, yes.
Okay, so thing is, there are 2 branches at the proximal part of the RCA CTO, which could be sometimes getting some problems, isn't it? It looks like a blunt stump to the proximal RCA.
That's right.
And what Madam was saying, that you got a large septal collaterals which is supplying, right up to the PDA and could be a good channel for a retrograde approach too. So both are quite convincing things. So what could be your first attempt to go ahead with an antigrade in this one, or right away go with retrograde and see?
I think,
Because
yeah, no, agree with your, it is not, it's a blunt stump with the two branches that are coming right where the total occlusion starts at the proximal cap. So which is challenging. But I think always in this case, we should always try antigrade. Let's give us some try with antigrade. And then if we think we are not able to make any progress, then we will definitely will go retrograde because we have a good retrograde channel there, the first septal connection.
Even the distal cap of the RCA also is tapering, and that also may give a good chance for retrograde if antigrade fails, isn't it?
Yeah, agree.
And I would say the few cases where you go with the retrograde to start with, and that will be the ostial lesion, like ostial LAD. There's no totally stump, and you see the left main, even your eye was dry. So that case, I would say you go back with the from PDA to the LAD collateral. There, same thing if there is ostial RCA, you have no way to go forward. So that will start with the retrograde to begin with. So with that note, while we are getting things ready, we are trying the antigrade first.
Yes.
And using the fine cross and.
So same thing. If we go, what are the over the wires things that we need to use? We will show you some slides later on. We still like to use fine cross. The fine cross has come with a newer generation where it's coated. The fine cross currently that we have is 130 centimeters, but it is not glide coated. Tip is not tapered, but they have a new generation that is come out, which is a tapered tip, and it is coated also because they want to go with the what other catheters that are available, which is a Corsair made by Abbott. Again, that comes 130. Assign, original Abbott, and that comes with the 130, 150. So if you are going, if you're thinking you want to go retrograde and you open one catheter, go with 150. That can be used for retrograde. And then of course we have turnpike. Various 5 different kind of turnpikes are available. We only keep one of them, turnpike spiral, one of that one we carry, and that also comes 150. And we used to carry 14, right? Which we don't. So these are the 3 that we carry here in the lab. So here we have decided to use fine cross. It all depends. You start doing your cases, you have your tools ready, and just get used to whatever tool you want to start using and familiarize with that, and just keep using that so you get good at it.
And once you start with a fielder, what will be your first CTO wire in this case?
So here, fielder, I do have the fielder, but I'm not sure if fielder is going to do anything. Yeah. It's a blunt stuff with so many side branches, so it may not do. I already have opened the first. Now, always there's the teaching goes. You go start with the floppy tip, whether you want to go with the regular fielder FC, or just even fielder XT, which is tapered. So these are polymer jacket as well as hydrophilic coating, so they can find some micro channels. So that maybe we're much easier. Good. You can put the slides on the side.
Exactly. Always when I CTO, a microcatheter is a must. It enhances the penetrating power. And when you have an antigrade approach, 130 centimeters is more than enough. But when you're planning to go with retrograde, like the Corsair Pro or even the Corsair Pro ES, which has come from the Asahi, the latest, the crossing ability is good. And even the Caravel also is a microcatheter which crosses all these septal channels very well. Considering the antigrade approach which is planned up, would you suggest more defining a fielder XT to an XTA rather than giving a fielder or a fielder FC?
So here, yes. So it's good. Like I said, what is that you really like to use? So we carry fielder one fielder XT. We don't have XTA or XTR. We don't carry both of them, but that's because
we have
XTA you have, not R.
Both are also.
You have both.
We have both of them now. Yeah.
But I never use them.
Yeah.
So we have just a regular fielder, not even fielder FC, just the regular fielder right now here open, and you can poke a little bit and see if you find any channel or so. If does not, I have the Miracle 6 to go directly. Now this is where people will say what is the next wire of choice for penetration, whether you want to go for Miracle, whether you want to go for Pilot. group of wires. So these are all the fielders that are available. This is our app that we have, guide wire app. So just briefly, it just tells you about every wire, who makes it, the length, the wire tip, and some important factors. More important is where you can use this wire. So it's just a snapshot of every wire that you want to know. So going back, so what's the first wire you want? I always like a miracle, because here you need to make a nice curve to, if you see here how the RCA is takeoff. One, guide selection, right? Many people will say they want AL 0.75. That's nothing wrong. I've still taken Lima because I wanted to be coaxial here, So feel this is probably the right guide. If we don't have support, we are ready with the AL 0.75 to change it. Then after that, we told you what's the microcatheter we are using. The wire is same, that whether you want to go with the next first wire could be a fielder, then next you want to go with pilot, because pilot is almost like fielder, but not tapered, but the tip load is slightly higher. So we have 150 and a 200 pilot. Or Miracle, which is Miracle 3, Miracle 6, Miracle 9. We carry both 3 and 6. I usually like to start with 6 because we can make a nice curve. But people like Gaia also, the Gaia series, that a Gaia Next, which comes with the pre-made tip. So it's one good thing, but here the negative point about that, the way the RCA take off, that could take a subintimal. That's my prediction. If we go directly with Gaia, that is why I think we would start with Miracle 6 here. And then after that, it's difficult to predict how the wire will behave, and then we can change. After that, we can change to Gaia, or we can go to Confianza, which could be 9 and 12 subsequently.
Yeah, well, exactly told, madam. And I also think like this looks like a blunt stem. You need an intermediate penetrating wire, because the workhouse wires like the fielder or even a pilot 50 would sometimes go to the branches only out. Pilot 150 is a good penetrating wire, and from the Gaia series onwards, intermediate, the one stop to the Conquest Pro or Confianza, it goes on more penetrating out. Only thing is the bend of the RCA, which needs to be concentrated. It can go subintima and penetrate and reach the RV once you cross 9 to 12 grams. So that needs really to be kept in mind.
Absolutely.
So I think that's a good thing.
And then if Progress 200T, and what is the other wire would be then high?
Then the Hornet.
Yeah.
Progress, So the Progress 200 again made by Abbott. Same, it's a combination, I would say, of fielder and Confianza, that you have hydrophilic, coating entire, but there is a polymer jacket also, but at the tip it is tapered and goes up to 13.8 to 14. Hornet is 14 tip load, and really, if you have calcific lesion, that's the time you go to the higher tip load wire, which is Astato. Astato we carry 20 and 40. But I hope we are not going to be using that here. That's for heavily calcified, CTOs.
Okay.
We call it Astato. We call it as Amogastra.
Amogastra.
Open at the last minute.
The heavy calcified CTO, like what could be your microcatheter of choice over there? Would you still think about Fine Cross, or
no? I
would
think
you go
then Corsair.
Yeah, Corsair.
In that case, Corsair.
Corsair or Turnpike. Like I said, whatever you are comfortable with. Yeah. Just familiarize with one and just be comfortable with one. And other thing that we teach here when we are doing our like is very clear with CTO. You need to have a finesse when you're doing the procedure. Have your angiograms and understand your proximal cap, distal cap. The goal has to be you penetrate from the proximal cap and you exit at the distal cap. So your length of the CTO, like here, whatever we length, more than 20, maybe 24 millimeters or so, that should be the goal, not just go subintimal, chop, and then find a lumen somewhere else and, do a PTCA and do 60 millimeter or 100 millimeter stent. That's not the right way of doing CTO.
Okay, so you're ready to start. I'll let me complete my presentation. We always present our data of the appropriate use criteria. So this will make it, because intermediate high risk finding, and it was not a proximal LAD. and patient is a dual anti-ischemic therapy now. So now also we learned with the recent our guidelines of ACC-AHA that the subgroup, particularly with the CTO, let's see what slides. Okay, slides are not moving. Yeah. So complex, these are subgroups now based on the guidelines. That one is that patient with a complex disease. They clearly say that revascularization to improve symptoms, and we know that some group with a multivessel disease and left main with a low ejection fraction, cabbage or PCI will be useful. And clearly that if the anatomic or physiological criteria for revascularization is not there, then nothing should be done. Diabetic patient, they actually made it very clear. There are three guidelines in terms of class 1, patient with diabetes and multivessel disease and a complex LAD. So basically the Lima to LAD, in those cases, that repeat revascularization, the cabbage is appropriate based on the freedom data, as we know, both mortality and decreasing repeat revascularization. Now then, 2A and 2B, they make up patients with diabetes who have multivessel CAD, amenable to PCI and indication for revascularization and are poor candidate for surgery, become type 2A, class 2A. And PCI can be done for long-term improvement of symptoms. And 2B is patient with diabetes who have left main stenosis and lower intermediate complexity CAD in the rest of the coronary artery. PCI may be considered as an alternative to cabbage to reduce major adverse cardiac event. The other group are basically calcified lesions. They give class 2A to the rotational atherectomy and 2B to the orbital. Then patients with the stent, they all say that patients who have developed restenosis, repeat PCI plan, another DES should be done. And clearly the other question have been that some patient can go for bypass surgery, and brachytherapy is also class 2B. Hemodynamic support really downgraded. 2B, yeah, 2B. Basically, in selected high-risk patients, elective insertion of appropriate hemodynamic support device as an adjunct to PCI may be reasonable to prevent hemodynamic compromise. Now, look at the latest one, and this is what I want to show. For the treatment of CTO, the lot of CTO fanatics really wrote the letters that this was the wrong recommendation. They have class 2B for CTO in patients with suitable anatomy who have refractory angina or medical therapy after treatment of non-CTO lesion. The benefit of PCI of a CTO to improve symptoms is uncertain because all the randomized trials have been negative, and therefore the CTO intervention PCI has been really downgraded from interventional point of view. Okay, Anu, tell us.
So this is where I'm going to show you. So with the fielder, we have made some progress, but I think I'm going to change it to Miracle 6. And if you can show the ceiling camera, the type of curve, so look at the, can you see?
Yeah.
The curve that I made.
The same 1 millimeter tip what we do for Gaia's.
And no, Gaia, okay, you can make
smaller.
that kind of a tip. It is way shorter. I had to make almost L-shaped curve there.
90-degree bend, I think.
Right.
Okay, good. Take this out.
So question comes is, maybe we can ask people, anyone that in the chat box they want to answer that what wire would they prefer now? Should be Gaia 3 or should go to Miracle?
Exactly. It all depends on the operator's choice also. Like
let's say what will be your choice? Yeah, what will be your choice?
I'm a Gaia man anyway. I'll always go with the Gaia 2.
Me too. I'm also a Gaia man. Yes. I would have gone with the Gaia 3, and Dr. Keeney actually is going, I know is going with the Miracle 6.
It made a good progress. It almost reached 3/4 of the CTO body, and I think it reached the distal tip. Oh, that's well crossed. Right.
And the point she made very clearly, avoid subintimal. Remember, a lot of data have all the subintimal device tracking. They all have a higher restenosis and subsequent asymptomatic total occlusions.
Exactly. In lesions like this, what happens is once the wire crosses the mid part of the CTO, the
Yeah.
antegrade flow stops. So
Yeah.
always a retrograde shoot should always be there when
Right.
the wire reaches the distal cap.
Absolutely. That's a great point. That is why we, despite we saw the lot of antegrade filling, we had the contralateral injection in this particular case. And as you mentioned also, that there is a little difference in the cost of the fine cross and with the Corsair. This is almost like Corsair is 1.5 times price. So we don't use Corsair as such to begin with as a primary, except some situation like calcific, which we discussed, you said, or maybe going to the side branch, stent jail. A tough situation. So then we'll go with the Corsair as the primary over-the-wire system. But otherwise, fine cross works in majority.
Exactly.
You want
The
to see
crossing of the
retrograde?
microcatheter, you can just see the drilling movement of what madam is doing now. That is exactly what is needed to cross the microcatheter below the distal cap.
Yeah.
And that is very important now.
And
It may take a little longer with the fine cross, and also later on, I need a black pen. I need to show in the drawing exactly why this one is better than. If we can show the slides of the microcatheter, Andrew, by the side, if you have them. It's almost there, but still having trouble.
And this is a type of case where wire has gone. And if you cannot advance a microcatheter, you cannot do the rota even in those cases. And of course, you can try the small balloon 10 0.75 in India that otherwise use the laser. So we actually have the laser in the room in case it is needed, but I don't think laser will be needed here.
We can remove this. It's not making the final thing.
think,
We could just go with the
smaller
one.
balloon,
Yeah, we could do with a smaller balloon.
1.75 or 0.85 would cross it, I think.
Yeah.
Or maybe even
1.1.
1.1 will.
So we have 10. So in America, we don't have 0.75 or 0.8 yet. We have only 10 Sapphire.
Sapphire, yeah. I think now what is really lacking is the guide support. Remember I said guide support with AL 0.75, majority people would go with that. And I have
Yeah,
a
I would
reason
agree
why
on
not to
that.
go. Yeah,
But this
so
one,
what we will do,
I think you pull back, wire will go. This wire will.
Can we
The wire
trap
will go.
the catheter?
no, I
Yeah.
will trap the,
wire?
we'll show them how to trap the wire.
Okay.
Yeah. So
Yeah,
we'll do
exactly. Trap the
trapping.
wire.
We'll take a 2.5, So we'll show what trapping is. So if you see here, from now on, just show the ceiling camera. So we tried the drilling. So SM, what we were doing, you see that you go clock, and then from the right, or with the right hand, and with the left hand, you're just advancing, gentle. And this movement have to be gentle, and so that your guide cannot be pushed out. Even though there is a good guide support from the opposite wall, many times, if you're very aggressive, the guide can come out.
And
So
get a one balloon ready. Yeah.
has to be gentle.
Take that.
Then, so for the trapping, you take for a 6 French, 2.5. So you see here, so you go by the side.
Yeah, it's not over the wire to
Yeah,
the
no,
side.
it's not the
that's
wire,
what-
just a side. That's it. Again, same side. Go all the way. So what I've done, wait, don't touch anything.
You can pull back a little bit.
So fine cross, you see there, it's in the guide. I'll show where it is. You can see the balloon coming.
Yep.
You see the balloon there?
Yeah.
Yes, we can see the balloon. Yeah, go up. And then your fine cross, go up. So you see the fine cross is right here. I'm going to go on cine. You see the tip of the fine cross?
Yeah, it's almost at the arch of aorta.
Yes.
Yeah.
Yeah. Good. We lost the pressure. Good.
Yeah,
Go
that's good.
14, 16. Your side hose?
Yeah.
You had side hose for the guide?
Yeah. Yeah.
Okay, then you won't go to the pressure.
Yeah.
So then just gently remove it.
Yeah.
Okay, now get me the
That,
1.2,
wire
1.0.
at all, that
no, 1.25 will go. Yeah, down. Go down. Now, once this is done, actually, there will be a lot of air that will be sucked in. So very important, once you take this balloon out. Good. Keep it. We'll use this balloon again. Let's make sure all the good. Okay. What is the balloon you have?
It's a 10 balloon now. 1 Sapphire, we have opened it. Good.
There's a Sapphire 1 balloon.
Yeah.
You're
Come
fine
on.
to go ahead? Oh, okay. Yeah, fine.
Yeah.
And length, is it 6 or 10?
6. 6.
6.
And key is not, if it does not go, laser is warming up.
Yeah.
Laser is ready. So this is
The
a
laser is
case to
something
me,
because, yeah.
uncrossable lesion. So that's it. So even if, I mean, I think if you want, we can really push the Corsair will go. Then you change to Rota if need to be. But I think this 1.0 balloon will do it.
But I think laser also is a good choice. Like in this
Yeah.
case, is uncrossable, and I think
Yes.
a 0.9 would be sufficient for this vessel. I
That's
think,
it.
isn't it?
0.9 exactly. Yeah, we can go up.
Problem. Yeah, go
Right.
up here because it's the whole thing is the seat. You have to dilate first.
Maybe a better catheter support from the aorta
Yeah.
with the catheter would, I think.
Although we can get the guideline or Godzilla also negative. Let's go further. Yeah. Yeah, good.
Okay, go up here.
Go up. Do you want to just show the laser today? If they can get ready quickly.
They want to see laser?
Yeah.
Yeah, I think laser also is fine.
Yes.
I think if you
Yeah.
can just cut off the fibrous tissue over there,
Yep.
I think
Okay, open the
it will be
laser.
better.
Negative. Yeah.
Down.
Balloon ruptured.
Ruptured?
Yeah, it's at 12 atmosphere. So 1.0 balloon very commonly ruptures. You go beyond 12 atmosphere. Right? If pressure went down or no? Yeah.
Oh,
Little cloud.
definitely, yeah.
Cloud, yeah.
You see that? This is typical when you have a perforation. I mean, little balloon.
Balloon rupture also. Yeah.
There's a bit of staining over there, I think.
Yeah.
Yeah,
That is all from the balloon rupture.
Right.
So this is
that's why I said 1.25.
no, but that may not have gone. Even
It
this
would
didn't
go.
cross.
It would go. No, this is okay. Whatever.
But it's a one balloon. I think it will be okay. I think.
Yeah.
It's a smaller
It'll be still okay.
Let's see little soft injection.
Anti-grade?
Yeah. Oh, sorry. That was a flush or what? 1 second, 1 second. Yeah.
Are you opening the laser? Okay.
Yep.
You're okay so far. Open.
You want to put a
Oh,
rotor side by
calibration?
side? You want to rotor side by side in case rotor
What?
goes? So you don't have to worry about this wire.
Now, how do you judge about the laser now anyway compared with the earlier laser? The cool laser now is
Yeah,
like
no, but
you know,
all but yeah, the same with the foot, the 60, 80, and so and working out quite some unexpanded stents as well as in uncrossable lesions. So we do about let's say 65 atherectomies of the 350 PCIs, about 5% every month. So we'll use in those 65, about 52 will be rotablation, 10 to 12 will be orbital, and about 2 will be laser in our lab. And that's actually the America also. It's about 60% rota, 45, 46, 35, 36% orbital, and about 2%, less than 2% is laser being used in United States. I know in India, it's a tough one because they have to bring the machine. Very few
Exactly.
centers have the laser bought it,
300
but
kg
otherwise it has to
machines.
come, right?
Exactly. It's a very,
Yeah.
very heavy machine, 300 kg
Have
machine.
very
And
heavy
now
machine.
we have reduced it to 250.
Yep,
The only thing
very
is
heavy
like
machine.
more of ISR cases on uncrossable, I think it is more useful.
Yes.
And even in East, I've seen some acute occlusions. MI also, my STEMI cases also, they use because of the slow flow is reduced when you are going to give these laser in thrombotic lesions.
Yep.
So what I'm going to start right
One
here.
second, not yet, not yet.
Okay.
I have to take the. Remember, we have to have
Dye
a
out.
dye out.
That's
Yeah.
okay. Little dye is.
Huh?
Little dye is fine. Yeah.
Little
Okay.
dye?
That's a very important point.
Okay.
Once the dye is not out, the chance of perforations are high. So flush the
Yeah.
dye
Okay.
out. That's very
Yeah.
important.
Good.
What's
Yeah.
so doing it.
There's still a lot of dye.
So we have to wait. It gives 20 seconds and then it is going to give us the noise. You can hear the noise, right?
Yeah. So what fluence and what weight?
40-40. Like right now,
40.
energy and fluence 40-40.
Okay.
Only question, do you need the guideliner to push it further?
That's one
I
mistake
also
we
think that.
made probably.
Take that.
The guide is backing up.
Yeah.
That's that tight area even where nothing was going.
Yes.
Should we
Anyway,
increase
I
the
think we should be able
distance?
to get it with the. I think one mistake we made was that one. Godzilla. Okay.
Not have the guideline.
Mm-hmm.
Get the guide a little better, maybe.
Cannot. See, this is the other
The
thing.
wire?
Then wire.
I think wire has gone down to the lower branch.
No. That's not the thing.
No, it's the same digital RC only.
No, pull back the branch. Yeah, now. No, you're in the branch. Pull back
Not
a
the
little more.
branch.
Yeah,
It
now
went
it's
a
good.
little subintimal somewhere. See, this is always an issue. You could have been in the intima,
Yeah.
okay, and then every time you come back forth, the this wires can then distally can go subintimal as we are
Yep.
trying to do advancing in the with the balloon. So I think we go with the
You want to try one more with a guide better position or no?
I think this wire is coming back and
Okay,
then it went
fine.
subintimal
Let's take it
already
out now.
once.
Good. Okay.
Give me this picture.
No, but this is all the no dye here.
No, this side. So I know
No,
we are
we
in
saw it.
lumen.
No, that's
I
good.
don't know.
No, that you are there now. We checked it.
What all laser catheters you have over there? It's 0.9.
No, we have
1.4.
1.4 also. Yeah. So no, but 0.9 will go. So we're just using the guide liner, and then we'll go. And we have not gone to the 80 yet, right? We are 40, 60. What did we do?
No, we now
Yeah,
60.
Yeah. So we just need the
better support.
yeah, a little support needed just because of the guide.
Exactly.
So other thing we could do also is you can now dilate the proximal area which already the catheter is gone with 2.5, so the Godzilla can advance further and then definitely laser will go. So one good thing about 6 French is you can do use a Godzilla and laser will go with that. Compared to rota, you cannot. Even 125 bar, this would be very tight fit.
What would be the option if laser doesn't cross with the guideline or sub-guide extension
No.
catheter support?
Yeah.
No, I think if laser will do as much as we can, then balloon will go with the Godzilla. It'll go now.
Remember, I always say that even if the lesion has not gone completely, whatever technique you are using, orbital, rotational, laser, it has softened the plaque, and your balloon
Exactly.
dilatation then will go in. So anyway, yeah. That,
And I think once the laser crosses, I think the two balloon will cross easily.
That's yeah. Then it will be no. Although I have a case where laser went, still nothing crossed. I used a 10 Sapphire that also ruptured. Then, but at least at that time you were able to get in.
Guide is
Yeah.
backing up.
Wait.
So what happens then? One did not cross after that?
Yeah. So then we went back with the Corsair, then put a rota wire, and then did a 1.25 bar. I showed in one of the crack the calcium of the Boston Scientific case. Very tortuous right coronary. Laser nothing crossed. Then we did laser crossed. Still 1.2 balloon will not cross. 1.0 balloon did rupture. Then we brought the Corsair again, which could to the tip, changed to rota, then did rota bar. That made the procedure successful. Okay, let's get the guideline a little bit more. Godzilla actually, good. Let's start.
Yeah, that's fine.
Good. Let's start now. You're in good position.
Now we're at 40.
I think we are 60 right now.
60, right, okay.
Get me 1.25 balloon.
Yep.
You'll go.
Yeah. Now you want 80 or no?
80, yeah.
Go. After this, we'll go to 80.
Maybe the proximal area is very hard on 5%. I
Yeah,
think laser has
very.
So the ideal way is you have to dilate because Godzilla is not going in. 2.5 dilate, Godzilla goes in, then laser will go.
Okay.
We have the 2.5 balloon, right?
Yeah, we have it. Yeah.
Get that ready also. You understand?
We're doing a 180-80 now, right?
Yeah. Okay.
Good. Okay.
Get me a 2.5 balloon. What I want to do is dilate the proximal part of the RCA and get the Godzilla further down.
Or do you want to just see your 1 balloon goes 1.25 now?
1.25. Okay.
Right? I think let's see the balloon goes in now.
Wait.
Yeah, I think 1.25 we can try.
Yeah, get the balloon now. Because 1
There's a
ruptured, so we are going with the 1.25 now.
Yeah, which
Yeah.
balloon is there? 1.25?
1.25 Sprinter
Sprinter.
Legend.
Okay.
I mean, whatever. We have 1.2 balloons made by Abbott. Trek balloons, 6 millimeter, 8 millimeter. This is 1.256 millimeter.
Abbott
I mean,
balloons are quite good.
Yeah.
At the same time, even the Japanese balloons like Thermo or Kaneka also are very good in hard lesions.
Okay.
You went in. Yep.
Yeah, I would
I
have
think
told you
it's
it would have
Yeah, same.
Yeah,
done
it's a
first
laser.
time.
Yeah.
You wanted
The
one,
same
no.
thing that once you make a half lumen with a laser, it'll go. Okay. Now get a 2 or 20, or we are 2.5 balloon
Yeah, we
already.
have 2.5. We can use
Yeah, good.
2.5.
Yeah.
Go up here again.
No, that's
What
too
I meant,
far.
we don't know
That too
that he could
proximal.
have done it with this to begin with. Okay, go.
No, I think it's a laser
To
effect
5.
more, I think.
Good.
It's a laser
Not
effect because balloon, 1 balloon didn't go that time.
Yeah, exactly. So some there may some path over there, the laser, and
That's
I
it.
think the balloon has taken over it.
Now we use, and we try to use the same stent brand. We use the Synergy XD. I know in India only Synergy is available. We have Synergy
Yeah.
XD and Synergy Megatron. And we are going to use the same Synergy here. But could be the long, 3 or 48. Or 2.75 48, one of them. Okay, now we
Trying
are
to
going with
dilate
the 2.5 balloon, which we use
2.5.
for trapping.
Okay.
This is the 12 balloon, Pablo. Hold the bar.
Yeah.
It's a wire tip in the small branch,
Yep.
I think.
Yeah, we pulled back already.
The miracle wire.
Good. We'll be
Go up
fine.
here.
We'll go now. Then you want 2.5 or 3 of non-compliant. You need non-compliant.
Get
Okay,
down.
this is 14.
Down. Go up here. Okay. Down.
Deflating. And anytime you advance your guardrail or guideline, or when you're deflating your balloon,
Okay, go up here.
okay. I'm deflating now.
Yeah.
Good.
Yeah. Now. I
So
think the
basically
guideline is-
telescoping your guideliner Godzilla on the
But I think the mid.
Good.
Yeah.
That's done now.
Good. Okay.
Okay.
That's
You want a
the
2.5 30 non-compliant long 30?
Okay, down. You want to what? Change to some other wire or just
Yeah,
went
no,
on this
change the
one?
wire. No,
Give me
rota.
a
Our run through wire. Short
give me
run
a
through.
run through shot.
Yeah. Good.
That's always important. Once a hard wire or a penetrating wire has crossed and dilated, it's
Then
always
change
better
it.
to
Yeah,
change the
absolutely.
wire.
Okay, we can bring back the
Godzilla.
Godzilla and the.
Oh, this is the issue with this wire.
I can just start the microcatheter and get the
Yeah.
exchange wire.
Good. Careful. Okay, good.
Yeah, put your wire will go. Put the side by side.
Looks like in a small vessel, the tip of the
Yeah, no, we are going to take that out now.
Needle. What did you want? I don't know. I think we can stent now. No? Huh? What? Not 10:15, 10:45.
Did we ever do IVBT of the circ or no?
No, we did in C.
So I'm just going side by side. Okay, let's see. So when you have the Godzilla and you are trying to double wire, you got to, now you see the fluoro, how I'm going to making sure that it will go in the lumen of the Godzilla. Coming out.
Good.
Yeah.
Okay. I'm
And take
taking
the
this
Godzilla
other
out
wire.
also. We don't need the
Yeah.
Godzilla.
This
Yeah,
way
better
now you
remove the
can
both
take a
wire.
picture. Yeah, and take a picture and then decide the exact length. And I think we can just stent it now. You want?
No,
No need
you had to dial it with the
again.
2.5. Yeah.
That was 2.5.
No, but non-compliant. You need I mean, that was compliant. We need non-compliant. A lot of distal dissection. But maybe just a nitro verapamil.
No, this disease was there even before.
Yeah. Good. Okay, here. Let's dilate.
What you're
With
taking?
the 2.530.
But let's decide the stenting strategy, the length
No,
and
but I think from RV branch, further down, you go, maybe they will require 2 stents. Or
Okay.
maybe before the bifurcation. Why don't we go all the way? Yeah, good. No, that's okay. That's 2.75,
Okay.
48, and the other one will be 3 or 38.
It'll be a full metal jacket again
Before the bifurcation, that's okay.
because
Is
there
it a
is disease.
spasm below distally?
Where there's so much, we are giving
I think
verapamil also.
let me go back to the original picture. If you
Yeah,
see
so
that
the
there was
recorded
disease
proof you can see, I
all
think.
the way. Yeah, there was a disease everywhere. So if you see here,
Yeah.
look at that. Yeah, distal RCA just before the bifurcation at the crux, about 50, 60, you can see there, right? And then
Exactly.
you see that acute marginal / RV branch. Distal to that, there is disease. So I guess,
Yeah, we need to put 2
metalize.
stents clearly.
yeah. So we have to make sure all that is taken care.
Take a 2.75 48 first. Yeah.
Now,
I
where
was
do you want me
thinking
to go?
2000
Keep
to the
going.
right, yeah.
Yeah.
Oh, and I
Go
was,
further. Let's dilate all of them. Yeah, good.
they want, okay,
Good.
go up here. Okay, good. So
Pulse rate went
yes,
up a little
what
bit.
the other thing that they will say, yes, I was it and then consider stenting based on the,
The distal lesions, I think
Yes,
this
Yeah.
is
yes,
So
yes.
no,
done.
but I would say that if you have the DCB,
good.
but otherwise you stent it. I mean, I was those will be okay. The focal stent concept. Yeah.
Would you prefer
No,
a
what I meant
DCB
is,
over
No, but we
before
don't have it.
starting,
Yeah.
we said we're not stenting, long stents.
Yeah. Good. No, but this is a lesion. There is a lesion there. We see clearly. Once you open proximally, this will become a little more significant. Now, why patients become a little
Yeah,
tachycardic?
tachycardic. You see
Talk
the
to the patient.
tachycardia, guys,
Yeah. Why?
with ST depressions. Just the
Take the
guide.
Godzilla out a little bit.
Yeah. Not to
Give 2.5 for IV low pressure. His EF is normal. Oh, he's allergic to metoprolol. Okay, we'll give some more verapamil then.
But it's sinus only, sinus trachea.
Yeah. Good. Let's go.
You want to what? From the crux
Just
backwards?
before the bifurcation. No, there is a big bulge there. So we just go disease of before the bifurcation. So enough room. Fill up more
So we take a
verapamil.
cranial view to see the distal RCA, the
Yeah.
bifurcation.
We can go a little epicranial now. It's continuously going tachycardic.
And not even
Any
that.
pericardial
ST
effusion, sir?
depressions.
Yeah.
ST
Pericardial
depressions.
effusion, anything?
Fluoro?
Mhm.
Go to our previous one. No.
No, you don't see a fusion.
No. Sine. So usually you will see an ariocaudal, an effusion. No. Go back to the cranial. Good.
Hold the wire, hold the wire.
Yeah, yeah.
Is there pressure difference between both
ACD
the
is good.
catheters?
No, but that, yeah. So it's a little, it's a guideliner, Godzilla
Almost like that,
pressure,
right? Yeah, that's right.
ventriculization, and so.
Oh, it's a long stent crossing well.
Yeah. And the second one could be a 30, maybe 28 or smaller.
Someday.
Yeah, right.
Yeah, good. That's where we are.
Good,
Okay.
right?
Yeah.
Okay. Going up. I think he had some kind of SVT which broke now. See the
Now
hemodynamics? Yeah.
it's fine.
Now it explains. 14. Yeah. It broke. 2-1 block actually. Verapamil working.
No, other thing is guide was too deep and then maybe sinus node.
Yeah. Maybe the guide and Godzilla
Tachycardic, yeah.
irritating the sinus node.
Okay.
Yeah. Let's pull
No,
back a
no,
little
not
bit.
even that. The pressure is going down.
Yeah. Good. Take the guideliner out.
Nothing to do with that.
Good.
I think 275 is good. Huh?
Proximally
28.
also?
Yeah. 28, no?
Or 3 or 28?
3 was too big SS.
No, no, we'll be okay.
Wait, let's take a picture.
Yeah.
Wait.
We'll decide. Let's open the ostium a little bit, and now we are going to. Good.
Okay. Ready?
Okay. Mega. Very good.
28 will not cover it up to the
No.
ostium.
32.
Yeah, 32.
3032. Good. I would say this wire out and Godzilla out. You don't need that now.
The taking Godzilla out is too complicated.
But I think a long stent is crossed distally. I
Yep.
think at 28,
We just have to cover it. Yes.
all right. I think we would be just lucky, I think.
Yeah. What do you have? No, you need 32.
Any questions they have on the bot? Chat bot. Box, chat box.
Your patient is fine, no symptoms, I mean, not having any chest pain or so. Okay. Good.
I think the pressures also are well stabilizing now.
Yeah, so everything is stabilized. I think it all was some unexplained.
No, the guide I think was irritating that probably the conus or SA node artery there. You see
Yep.
I think
Good.
should we cover from the ostium of the RCA?
Yeah, we
that?
did moved out a
we're
little
coming
bit.
up to there. That's why we took 32. Okay, good. Hmm. Probably needed 30, right?
No, that's okay. Little extra overlap, there is no problem.
Let's make sure it's not going in the. You didn't want Godzilla, and now you see. Kept saying, take it out, take it out.
No, but you have gone in.
No, it's sticking out too much.
Good.
Okay. Now we are okay.
Good.
Okay,
that's
now you
fine.
give some dye. Yeah.
Pull the catheter a bit proximal.
Okay, ready?
Yeah.
Yep.
Mm.
Good.
Pull back a little bit more.
It's okay.
Yeah.
Yeah.
No,
Not,
no, no. We don't want to double overlap
Okay.
in that RV branch. Okay,
Good.
now.
Okay.
So wait, some dye.
yeah. Chance of occlusion of a side branch is high when you have an overlapping two stems.
Yeah.
I would say go up and then I'll pull it out, right? No?
Okay.
Okay,
Going
now
up.
die. Just confirm. Okay, good.
Okay. This is a 3032 synergy. We deploy 16 atmosphere.
Yeah.
Patient is
Keep
nicely
the stent,
sedated.
keep
You
the
probably
stent
can
in
hear
the
the snoring there.
Yeah, good. Down.
especially in the ostium is quite difficult in RCA when a breathing patient is there.
That's right.
And a long stent.
Going on.
That's right.
Yeah, long stent is not easy to place. Yeah. Okay,
And
good.
the flaring is the more important
Down.
part also. That now showing the flaring of the proximal stent prior
Yes.
to ostial flare.
Okay. Now bring the guide on the balloon so that it doesn't destroy the ostium. I mean, little hanging stent. Good. Ready? Beautiful. Take everything out. We get nitro. I mean, verapamil more. No, we don't need nitro.
We're just giving a little bit verapamil. Apparently cannot allergic to beta blockers. Get the heart rate down. We're just giving vasodilators to take care of the distal vessels.
So that tachycardia, I'm still not clear what it was.
As
It
soon as you
has to be
disengage the
relation
guide.
of that sinus
Oi.
nodal artery.
Yeah.
Yeah. Good. That's good.
Mm-hmm.
Yeah. Now the last picture we always say use the low mag without moving the camera. Same particularly in the complex cases where wire has traversed to many areas and to see any distal wire tip perforation. So you are cautious what to do if something else happen. No surprises. So we are waiting now. We are ready to take a picture. Good.
Beautiful result.
Beautiful.
It's the most
Fantastic.
important thing to see the distal PDA, PLV or the distal branches are
All the
not
branches
perforated.
were intact. That is where we wanted. And I'm glad that we were able to show the latest of our guide wire aid. Actually, it's
Does he
still
have those?
website. It's still on the website only.
No. Its app
The
is there.
app.
App is
Yeah.
available.
Yeah.
The
So-
guide wire app is available. Do you have the micro catheter pictures? Show the micro catheters. And I can show. Okay, so the total contrast is 120 with the 2 injections and air karma of 0.6. Ideally, air karma should be less than 2. So 0.6 total fluoro time of 22 minutes. Yeah.
and tap of 46. Yeah.
No,
And that too a
go back
CT case.
to the picture. Yeah, so this is what I think we spoke about. Corsair, fine cross is what we used, and then the turnpike. So if you look at the pictures here, right, both Corsair, turnpike, look at the tip, they're tapered, and there is a hydrophilic coating. Yeah, that one, go to the Corsair. Corsair also is tapered, hydrophilic coating, and go back to this fine cross. This is the new one.
MG. Yeah.
Where's the old one?
But that the more important is the Corsair is 1.3 French.
Yeah.
Very tapered, thinner.
Tapered tip. Yeah.
Yeah.
Yeah, that is tapered. Show me this Corsair, that the one we opened.
Right. So
Uh,
fine cross MG. That's what we have been using. Except that, as I said, Corsair, because of the design, Turnpike and Fine Cross are the same cost, but Corsair is little expensive. It's
So
about
go back to the picture of the Fine Cross MG. Yeah, big picture. So it is not tapered, but they have the newer one which is tapered. The one that we used is not tapered, and the reason for that, why that is helpful in this particular situation, if you see there, because it was blunt stump with two little branches coming off. Now you may say, okay, tapered may be a better one because tapered could keep you in the center. That's one thing. It could, but I always prefer, if you have a blunt stump, use the micro catheter that does not taper. It is also blunt, so you are able to be in the center of that blunt stump. That's how I think we showed that here. That's number one. Number two, guide selection, right? We know later on we struggled with the Lima guide because there was no good guide support. Should have been AL.75, which gives a good guide support. You need, whatever guide you take, the guide has to be coaxial so that you are entering the proximal cap at the center, and not, if you start the proximal cap but then you are in the side and it takes you subintimal, you got to be at the center. That is how I believe that the Lima guide helps there for us to be in the center. Sometimes, yes, depending on how the RCA takeoff is and all that. I also do use AL.75, but that is not the favorite guide as usual, because I often see when AL.75 is sitting this way, you end up starting itself subintimal, and then you lost your game. So that's why the guide selection, which was the Lima, and then we used the Fine Cross, just to make a point here.
And at the same time, I think one of the things which you could have done when we knew that it was a difficulty, that go with the Godzilla or guideliner to begin with. So I think we did a little later in the equation.
There's plus minus.
Yeah.
You have Godzilla to begin with, and then you have it there. The risk of thrombus formation, all that is there. So when you need it, use it. So have it ready, and I think use it at the right time.
Yes. Okay.
Other thing was that you see that we, even with the Godzilla, we were not able to progress it further. That's because proximal lesion was not opened up well, so Godzilla was not able to progress. So you have traversed maybe 20 millimeter of the CTO with your 1O balloon, 102 balloon. The distal is not able to go. You can take a 2.5 balloon, dilate there, get your Godzilla down, and then at 1.25 balloon will then cross the distal cap. That's other option also.
All right. So Joseph and George, any other question from your side? But from our side, we are done. The case presentation with the appropriate slide presentation, we are done. And more importantly, that CTO, we need to be really careful which case we do CTO. It has to be clearly documented that patient has symptoms and or ischemia on whatever testing we do, whether stress echo or stress MPI, and then only it is justified. They definitely have downgraded CTO because 5 randomized trials of the CTO have failed, except little quality of life in the Euro CTO, but otherwise every trial of the CTO against medical therapy has failed. Even Korean guys, every trial of the Korea comes positive. Even their trial failed. So key, the CTO need to be done. Of course, it could be part of the complete revascularization. We know that patients with the CTO left with the multivessel disease have bad outcome, but there's no study has shown by opening it, you improve the outcome. So that's where we are. But I'm glad that everything went well. We had a lot of teaching points, and Dr. Keeney showed latest on the GuideWire app, and will be useful for everyone. And every GuideWire which is available, all details are available there. So maybe we can hear the closing remark from Vijayan.
So it was a wonderful case, sir. Learned lots of steps, especially the use of guideliner and how you manage to open a CTO that with a long segment in a time span of just 45 minutes. So it was a very, very good job, sir.
All right. So you start
Thank
your
you.
presentation. I'll join you in 3-4 minutes.
Bye-bye.
Bye.